Giuseppe, thank you very much, Professor Abdallah, on the invitation. As I said, it is not just the courtesy that I'm saying that I always feel excellent here, and that I am very happy to learn that the cooperation between the Emirates Cardiac Society and Heart Failure Association of the ESC will become better and better. You all know, and it is not news, that we are witnessing the global epidemic of diabetes, and even more unpleasant is to understand that we expected the number of the cases to rise by 1.5%. The most important thing is that those cases are mostly unknown to the patient, so they don't have the chances to know that they are sick for the decades. On the other hand, we are also living in the epidemic of heart failure, and I have a pleasure to show you the first edition of the Heart Failure Association Atlas, which is the survey done by Heart Failure Association. And the second edition of this is just ready to start. We learned that the incidence of heart failure in Europe is 3.2 per 1,000 person years, and that the median prevalence is 17.2 per 1,000 person. So it is very important to understand and to have those data from our own countries and our own continent, because that gives us the idea how frequent and how dangerous this disease is. On the other hand, diabetes is the most important comorbidity in heart failure. We say that it is not only early, but that is often a symptomatic complication. And if you look at your own practice, you can be awarded between 25 and 40% of diabetes, of patients with heart failure have diabetes. And on the other hand, the most cases are undiagnosed. And this undiagnosed heart failure was detected in 28% of the patients with diabetes aged less than 60 years. Even more, diabetes is increasing risk of developing heart failure, and it is associated with poorer prognosis. The duration of diabetes is one of the most important factors in appearing in the sense of outcome who would be adverse. We know that 33% approximately patient with hospitalized heart failure has diabetes, and also 46%, even half of those patients will be rehospitalized. The toughest form of diabetes are associated with a higher incidence of serious New York Heart Association class, and the incidence rate of diabetes by New York Heart Association class can be seen as an important indicator of further assessment of the disease. In addition to that, the heart failure hospitalization are more frequent in patients with diabetes, and not only this, but the mortality, both all-cause and cardiovascular mortality, is much higher in patients with heart failure and diabetes. Hospitalized and outpatient heart failure and diabetes patient has high incidence of both all-cause and cardiovascular mortality. So it is clear to us now that this association of diabetes and heart failure is something which needs to be recognized on time and to be treated and prevented if possible. The major problem stays the effect of diabetes on the myocardium. This is so-called entity, diabetic cardiomyopathy. However, we are still far from, first of all, defining this entity, and the second, find how we can approach to the diagnosis and eventually prevention of this disease. However, in the last 5 years, we have a major and very important progresses, and these progresses came from the field of anti-diabetic drugs. As you can see, all anti-diabetic drugs can be divided in those who are increasing the risk of heart failure, those who have a neutral risk of heart failure, and who have the beneficial effect. The old, very frequently used, but an excellent drug, metformin, appears to have a positive effect on the outcome, including heart failure in patients with diabetes, and in many countries, including your area, is the first-line treatment options for those patients. If we look on the other drugs, and I'm going to discuss only those with a positive effect, glucagon-like peptide, one receptor antagonist, are a very important drug. They have a neutral effect on the risk of heart failure hospitalization, talking in general. Lixenatide, liraglutide, semaglutide, and exenatide are very important. You may know the major breakthrough in those drugs is semaglutide, which is now considered not only the drug for treatment of diabetes, but also for the reduction of the body mass index. Neutral effect is practically very much confirmed on the meta-analysis in phase 3, randomized controlled trial, and therefore these drugs are also considered to be safe and preventive in the setting of cardiovascular disease, but also heart failure. However, the major breakthrough here are SGLT2 inhibitors. And what we are facing now is the steep rise of the use of SGLT2 inhibitors from the field of anti-diabetic drug to the heart failure. And now comes a very simple but very important thing that we need to teach our postdocs, our younger colleagues, that SGLT2 inhibitors are not anymore the drugs used as anti-diabetic, but also the drugs, and on the first place, the drug which can be used as drugs which improve cardiovascular outcomes. As we know, SGLT2 inhibitors are reducing the possibility of developing not only heart failure, but also CKD in patients with diabetes. It is not only empagliflozin, but also CANA, DAPA, ER2, and other newly introduced drugs in this area. You can see that they are very important in prevention of heart failure as a primary prevention in the patients with diabetes, but also in chronic kidney disease. As a secondary prevention, they were shown to be extremely efficacious in the patients with HFrEF, HFpEF, as well as in acute heart failure. Everything started with the EMPA-REG outcome, which demonstrated rapid cardiovascular death reduction in the patient with empagliflozin. And I would like to draw your attention on the early effect after 18 days of drug in those patients. That was followed by the many trials done in this area. In HFrEF, Emperor reduced, demonstrated an excellent reduction in cardiovascular death, but on the first place, heart failure hospitalization. And also the composite renal endpoint were affected to the same way, giving us the possibility to understand that the drug is acting on the cardio-renal axis. These composite renal endpoint, which were positive, are extremely important. As you can see, the hazard ratio is 0.5, which is very good and which gives us the possibility to treat those patients in the complete sense to prevent the development of the heart failure, but also chronic kidney disease. 2021 guidelines put something very important points forward. So we are now using quadruple instead of triple medical treatment, including SGLT2 inhibitors. Simultaneous instead of sequential introduction of the drug, and which was revolutionary, was the patient profiling and strategic phenotyping introduced by Professor Rosano, present here, which is giving us for the first time in the heart failure history, the possibility to approach our heart failure patients, to give them the drugs with low side effect profile, but an excellent efficacy. So as you can see, the drugs are divided by the level of the heart rate, blood pressure, presence or absence of atrial fibrillation, and presence of absence of the CKD. And that was extremely important because in the European guidelines, SGLT2 inhibitors were put forward after these big trials as a class of evidence, one level of evidence A. Americans were followed, and as you can see, the SGLT2 inhibitors were seen as a backbone of the treatment of diabetes, acute cardiovascular disease, kidney disease, and heart failure. Therefore, we are now facing the completeness of European and American guidelines, followed by Canadian and Japanese guidelines, which are recommending those drugs on the first place. What's the mechanism? I can tell you that this is a long-lasting and not clearly defined stories, the reduction of the preload and afterload, the effect on kidney, as well as the effect of cardiac metabolic state. But at the end, what is important for us as clinicians to know that this drug is very active. The next surprise comes from the field of very cumbersome disease, and this is heart failure preserved ejection fraction, in whom empagliflozin was shown to reduce the composite primary endpoint of cardiovascular death and heart failure hospitalization. Therefore, having in mind what we learned so far, we have an excellent opportunity to improve the cardiovascular complications of diabetes by the early beneficial effect, from reducing of the clinical risk factors to reducing the progression of the kidney disease and cardiovascular events, to reducing its hospitalization and finally mortality. So we have the drugs which is overarching in the whole cardiovascular continuum. However, ladies and gentlemen, and this is the key message from me to you, the usage of the cardiorenal protective agents remain very low. We are facing with a different but very important drawbacks and obstacles. And what will be the important part of this meeting, but also the important part of all our associations, is to go ahead and try to implement those drugs as much as possible. Therefore, it is my great pleasure to say that cardiovascular complications in diabetes are possible. They can be prevented and treated. And first of all, it is time to act now. It is time to develop the systems and activate the educational and social responsibilities in order to do that as fast as possible. I would like to thank you very much for your attention.